This is a case from a few years ago. It's actually my first clinical limb ischemia case, and fortunately, it's still my worst SFA case. But I think there's some learning, and I've definitely learned a lot since this case, and I would probably approach it a little bit differently now. But let's go through it. So this is a 65-year-old woman who has some significant comorbidities. She does have diabetes, has known significant PAD, some renal insufficiency. She has a history of some amputations bilaterally and a history of a right fem pop at another institution many years ago. So she had a recent amputation of two of her left toes, and the base of the toes were not healing well after her amputation. She also developed a wound in her left heel. So her podiatrist referred her to me for an evaluation of her vascular disease. So she did have Dopplerable DP and PT bilaterally, but they were much worse on the left. So we obtained PVRs. And these are the initial PVRs. I don't know if you can read these numbers real well, but about 0.4 here on the left, which corresponded with her wound. So we sent her for angiography. Her renal insufficiency was relatively stable and not too bad. So we felt using 50-50 contrast was reasonable in this case. So you can see not a lot of aortic disease. She does have some iliac disease, mild, and then she's got some common femoral disease, maybe mild to moderate here bilaterally. We didn't interrogate the right leg as much because her PVRs are much better on that side, so we focused on the left to preserve contrast. And you can see her SFA is completely occluded here. And you'll see as we took more pictures that her SFA did reconstitute. There's a collateral going here, but there's severe disease after that. And then you'll see the SFA travels distally and then occludes at the level of the popliteal and kind of reconstitutes in this one vessel, AT, that does go down all the way to the foot here. So, I guess thinking about, I'd be interested to hear people's thoughts on how you'd approach this. She's 65, she had a lot of comorbidities, some renal disease, history of vascular surgery before. Potentially she could have been a reasonable surgical candidate in this case, and she did have a decent target. So I'm sure my vascular surgery colleagues are kind of cringing that we went endovascular with this, but we thought we'd give it an attempt. Patient wasn't super interested in surgery again, but it was a reasonable option, I think, in this case. So I was able to I came up and over and I crossed through the SFA just with the angled glide wire and an angled glide catheter. And I did get subintimal in the distal SFA after that reconstitution distally. And then, I kind of re-entered in the popliteal area and then made it down into the AT. I did use IVUS with an 014 wire, and I did show that I was true lumen, certainly from the popliteal into the AT, and for a good chunk of the SFA. So I felt okay going in with angioplasty in this case, and I just used a chocolate balloon here and kind of ballooned up to open up the vessel. And had a reasonable angiographic result, and I felt that with IVUS there was enough dissection in the SFA. I'd probably handle this a little bit differently now, but I did go ahead and just put stents through most of her SFA. I used drug-eluting stents all the way up to kind of the ostium of her SFA here. And we had good flow. She had pretty good flow distally here. It was very brisk. Some of this was spasm that kind of resolved with some nitroglycerin. So I felt that I established inline flow. I thought this would help her. When we finished the intervention, her Doppler signals were extremely strong in that leg. We had brisk flow. And so, I kind of was happy with my result. Took her back to the room several hours later. She developed some leg pain and came back relatively abruptly. And I went to examine her, and she had lost those really strong Doppler signals in the left foot. So I knew that something had happened, and I got repeat PVRs. And on exam, it looked like something had happened proximally. So I got kind of urgent PVRs at the bedside, just to kind of get a lay of the land before I went back in for a repeat angiography. And sure enough, her PVRs on the left looked terrible, even worse than before. So I knew there was a proximal problem. So I took her back for angiography, and I revealed that her SFA had shut down at the ostium. And probably some of her collaterals were compromised as part of the intervention, so that's why it looked worse than before. And then she had kind of this complex dissection in her common femoral artery. So I knew I had to deal with that at some point, but I wanted to get her leg open because she was having some rest pain and her PVRs looked terrible and that was relatively abrupt. So I'd be interested to hear how people would handle an acute shutdown of a stent like that. But I felt if I could get a wire through there and feel confident that I was in the proper place, that I could just give some low-dose lytics and it should resolve relatively quickly. This is a brand new stent. It's all thrombus. So I took a 50-centimeter Ekos catheter and I took some angiograms down here in the AT to make sure that I was parked in a good spot. There was no thrombus distally. It all seemed to be kind of in the area of the stent. And I just ran this for a few hours. I ended up running it overnight because I wanted to make sure we had a good result. And I brought her back the next day. And you can see repeating angiography. Anybody that's used low-dose lytics in this setting of a stent thrombosis, it clears up relatively quickly and fairly thoroughly. So it looked good at this point. She had good runoff again to the AT, and she had a good runoff to the foot. But then we had this to deal with, this dissection. So I went back and kind of scrutinized my pictures, and you can see she's got this eccentric plaque in her common femoral. I did have my ancel sheath down here, and I don't know if the ancel sheath dissected during the case or if the proximal part of my stent caused a dissection here. But you can see there's a branch coming off here, and then you see the same branch here, but you also see this hang up here, which is the area of the dissection and dye. And you can see that my common femoral is much more narrowed than it was here in my initial angiogram. So clearly something happened here that I think caused this, caused flow to be poor here into the stent and caused it to shut down. So I don't know how people would handle this in this situation, whether you try to, this patient just had a relatively extensive intervention endovascularly. Would you then just try to fix this endovascularly? At the time, I felt that I would possibly compromise my profunda here, and I felt that I would maybe get myself into big trouble here if I just try to stent across this. So I did involve one of my vascular surgery colleagues and kind of said, hey, can you just come in here and fix this up with a quick procedure? Their thought was, with the new stent at the ostium, yeah, exactly. With the new stent at the ostium, they didn't feel that just an endarterectomy here and fixing this would be sufficient. They thought they would have trouble clamping and hemostasis would be difficult. So they opted to just, they did some vein mapping and they opted to do a full femtibial bypass on the patient. I'd be interested to hear people's thoughts on that as well. But so she did have, she did have a dissection there. It was compromising her stent, so she had a common femoral endarterectomy and a femtib bypass with a vein conduit, and it kind of her pulses afterwards, or her Doppler signals were excellent again, and she actually had a good outcome. I still see her and follow her, and she's doing well. But I thought this was a good learning case, being able to scrutinize your final pictures at the end. I probably should have seen that dissection on my last shots, which I didn't. And if I did, I might have been able to treat that endovascularly more simply than letting it close down. Thank you.